We are very lucky to be joined by Caylee Brown. Now, Caylee is a PGY2 emergency medicine pharmacy resident at Mission Hospital in Asheville, North Carolina. Caylee, welcome. How are you doing today?
Doing pretty well, Nick. Thanks.
So, working in Asheville, I think arguably, would you say the brunch capital of America? I think maybe like a nickname. Let us know. Where should the people go? What's the brunch spots? If you Google it, I'm sure 800 restaurants come up.
Yeah, I think if I had to pick and one that I go to most frequently would be Biscuit Head. There's multiple locations, but I think the one that's a little bit more less known is the one that's actually right close to Mission Hospital. So on that busy Sunday morning when there might be a longer line over in the West Asheville location, maybe just head closer to the hospital. But they have by far the best biscuits and gravy that you could ask for in Asheville. So like best choice in my opinion.
Are the biscuits as big as their head or biscuit head, just like that's all that's on their mind?
Probably both. Also, their biscuits are huge. So you really don't need more than one, which when you first go, you can kind of want to order everything off the menu, which I did the first time, and you walk out in like a food coma. So if you want to take it for like try that out, go for it. I hope you finish it all, but I couldn't.
That sounds like a rite of passage that you have to order everything you want on the menu the first time you go. So, all right, good tip, biscuit head. Now, one of our favorite mantras in critical care and emergency medicine, go big or go home. Now, we've pointed out in other episodes the statement isn't always true. But Kaylee's going to highlight a disease state where not only is this true, but it's vital to our treatment success. So take it away.
Yeah, so today I'll be talking about SCAPE, and I first kind of want to start by setting the scene with a patient that may present to your ED. So our patient is a 65-year-old male who is presenting via EMS with complaints of shortness of breath and chest pain. He has a history of heart failure and struggles with medication compliance. On arrival, he reports that the shortness of breath started about 2 hours ago and has continued to get worse. His vitals on presentation show severe hypertension with a blood pressure of 240 over 185, which you heard that right. That was 240 over 185, with a heart rate of 120 beats per minute, respiratory rate of 35 breaths per minute, and an oxygen saturation of 83% on 10 liters on a non-rebreather. On physical exam, he's in respiratory distress, he's diaphoretic, and you hear some bilateral wheeze, what's present on auscultation. Um, he also has a past medical history of hypertension and heart failure with reduced ejection fraction. The ED provider performs a bedside ultrasound, which shows some B lines throughout all the lung fields, and the provider is suspicious for sympathetic crashing acute pulmonary edema. So they call a respiratory over, place him on BiPAP, and now they're asking pharmacy's help with initiation of a nitroglycerin drip. So that's kind of setting the stage for where we're going to go further. So what is SCAPE? So SCAPE is a sympathetic crashing acute pulmonary edema, which is a severe form of heart failure where patients present with acute onset hypoxia with a markedly elevated hypertension, as was referenced with the blood pressure of 240 over 185. SCAPE can develop over minutes to hours and can lead to a dramatic overall clinical presentation. So we're thinking low oxygen saturation and a high blood pressure, developing rather quickly, usually within less than 6 hours of presentation. So now that you kind of have an idea of what SCAPE is, I kind of want to talk more about the mechanism of SCAPE and how this can kind of arise in our heart failure patients. So it's a dramatic subset of acute decompensated heart failure. And this occurs when there's a decreased left ventricular function, causing an increased pulmonary capillary hydrostatic pressure, which leads to an inability to effectively pump blood through the aorta. And this dysfunction leads to an increased pressure within the system, causing increasing pulmonary hydrostatic pressure, which pushes fluids out of the capillaries and into the interstitial space, and then the alveoli, which will cause pulmonary edema. Additionally, a sympathetic surge can occur as a stress response to the pulmonary edema. So in patients with left ventricular dysfunction, there's a predisposition for an increase in sympathetic tone and a release of catecholamines, which can actually precipitate flash pulmonary edema. So ultimately, you end up with an increased afterload, which further increases the hydrostatic pressure, leading to pulmonary backflow, which kind of causes this vicious cycle of a sympathetic surge due to the catecholamine release and RAS activation. So these patients will spiral pretty quickly, and our goal here is to really prevent their spiral and prevent intubation. So now that we kind of have an idea of what SCAPE is, the diagnosis of SCAPE can actually be a little bit more challenging than what we anticipate. So patients presenting in SCAPE, the diagnosis has to be based off of their clinical presentation in conjunction with their patient history. So the clinical presentation can show rapidly progressing acute hypoxia, usually with an oxygen saturation less than 90%. And that's also within the time frame of oftentimes in less than 6 hours of presentation. So they're not going to be hanging out in this low oxygen state for quite long before they come to your ER. They'll also present with that marked hypertension, usually a blood pressure greater than 160 over 180 or greater than 160 over 100 at a map of greater than 120. They'll be tachypnic with a respiratory rate greater than 30 breaths per minute. So kind of basically what our patient was presenting with. The physical exam can show rails and crackles on pulmonary auscultation, and the bedside ultrasound showing B lines is another key diagnostic factor here, showing the pulmonary edema that these patients are experiencing. Looking at the patient's history, so this could include heart failure. We should be asking about their medication compliance, specifically if they took their meds that day or not. For example, our patient struggled with medication compliance, so another kind of factor there that we needed to consider. And once we kind of take those into account, we also have to think about some other pulmonary or acute heart failure conditions that could also mimic SCAPE. So thinking about some of those mimics, which can include congestive heart failure exacerbations or general hypertensive urgency and emergency. But the two key features of SCAPE are really that it develops quickly over hours, over a few hours, and patients often present with that very high systolic blood pressure. And these can really be your differentiating factors when comparing SCAPE to other acute decompensated heart failure episodes or a cardiogenic shock picture, when your patient may instead report symptoms that had progressed over a couple days, or a presentation with a low blood pressure or a MAP of less than 65. So that's kind of your key things to look into when you're trying to assess your patients when they first come in. They're going to be in distress. So you're going to want to be kind of thinking through these things pretty quickly, and making sure that we're ruling out some potential mimics. And now that we kind of have an idea of what SCAPE is and how it presents, we need to determine our management strategies. And currently, there are no guidelines that outline preferred treatment strategies for SCAPE. So we have to rely on a few studies that we have available and also a consensus statement that was released from the American College of Emergency Physicians for our guidance here. In general, though, the management strategy for SCAPE relies on the use of non-invasive positive pressure ventilation with either BiPAP or CPAP and nitroglycerin, which has become kind of the standard regimen for these patients. And this is with the goal to prevent the need for intubation and subsequent mechanical ventilation. So with that, I'll mainly focus on the role of nitroglycerin in these patients, and that's kind of what I'll jump into now. So nitroglycerin is known as a vasodilator. It produces preload reduction through increasing cyclic GMP and forming nitric oxide, which will result in smooth muscle relaxation. This effect is predominant at our conventional doses of nitroglycerin, which we think of more about 5 to 20 mics per minute. And then during SCAPE, though, our goal is to really target that afterload reduction. So that's our key piece here, where in SCAPE, we're having that sympathetic surge, that increase in afterload. So we're really preventing our heart from kind of pushing the blood out through this mechanism. So by targeting this afterload, we'll have to use higher doses of nitroglycerin, commonly referred to as high-dose nitroglycerin. And this can be achieved through administration of bolus doses of about 40 mics to about 1,000 mics, or initiation of nitroglycerin drip at an infusion rate greater than or equal to 100 mics per minute. So this is a little bit different, a different way to use nitroglycerin than we're conventionally used to using it. And thinking in terms of our chest pain patients, We'll use lower doses. And if we're starting a drip, we'll usually be using that 5 to 20 mics per minute range. So here we're going to be really pushing the dose higher to target that afterload. It's important to also think about populations that we should be avoiding nitroglycerin in. And in those patients, we should be using different strategies to kind of reduce that afterload. So nitroglycerin should not be used in patients with any contraindications to nitro, which includes recent use of phosphodiesterase 5 inhibitors such as sildenafil or tadalafil. If the patient is presenting an acute myocardial infarction, as well as patients with moderate or severe aortic stenosis and hypertrophic cardiomyopathy. Now I want to kind of briefly go into our literature since that's kind of the meat of how we base our recommendations and how we use high-dose nitroglycerin. But there's still a lot of questions remaining how we go about administering nitroglycerin to these patients. So some recent case studies describe the use of high-dose nitroglycerin in patients presenting with SCAPE and have shown that the use of nitroglycerin is safe and efficacious for resolving SCAPE. In 2023, the Taming the Tiger case report was published, which described a patient presenting in SCAPE that received an IV nitroglycerin bolus of 1,000 mics, followed by a continuous infusion of nitroglycerin started at a rate of 100 mics per minute that was further titrated to 250 mics per minute. This patient also received 2 additional nitroglycerin bolus doses of 1,500 mics IV given 15 minutes apart, and then an additional 2,000 mic bolus dose. Ultimately, this patient received a total of 9,000 micrograms in bolus doses and 7,600 or 76,000 micrograms from the continuous infusion, which was over a 12-hour period. This case report showed that there was no adverse effects reported, and the patient was discharged after 8 hours of observation following resolution of their SCAPE episode. There are also a few randomized controlled trials available, and one of the first trials discussing the use of high-dose nitroglycerin in SCAPE was published in 2007 by Levy and colleagues, and this was an open-label trial investigating the use of 2,000 microgram nitroglycerin bolus doses given via an IV infusion every 3 minutes. The primary endpoint of intubation occurred in 13.8% of patients that received high-dose nitroglycerin compared to 26.7% of patients that did not. And the trial reported 1 episode of symptomatic hypotension in the high-dose nitroglycerin group. So overall, this trial showed that high-dose nitroglycerin was relatively safe with only 1 patient experiencing hypotension, and it did prevent the need for intubation. And then next in 2021, Matthew and colleagues published a prospective observational trial that evaluated the implementation of a SCAPE treatment protocol, where all patients received non-invasive ventilation and an initial nitroglycerin bolus dose of 600 to 1,000 mics based on their systolic blood pressure, which was followed by a nitro infusion initiated at 100 mics per minute and titrated until resolution of symptoms. They had about 25 patients included, and 11 patients had symptom resolution at 3 hours, followed by 14 patients at 6 hours. And only 1 patient had to be intubated, and there were no adverse effects or events seen. And then finally, most recently in 2023, the authors of the Taming the Tiger case report published an open label randomized controlled trial. So finally, something that we really want to hang our hat on, which compared the use of high-dose nitroglycerin to low-dose nitroglycerin in patients with SCAPE. All patients in the trial received non-invasive ventilation, and patients in the high-dose group received a nitro bolus of 600 to 1,000 mics, followed by an infusion starting at 100 mics per minute. The primary outcome of the was symptom resolution at 6 hours, which was seen in 65.3% of patients receiving high-dose nitro, compared to 11.5% of patients receiving low-dose nitro. And the authors did not report any adverse events for either group. So as you can see, the literature here has really been showing that there has been a positive correlation in the use of nitroglycerin with high doses to prevent the need for intubation and leading to symptom resolution in these patients presenting with SCAPE. And the fact that there has been no major adverse events kind of reported in these trials, it also proves that it has been a relatively safe treatment option that we can utilize in these patients. So now that we've kind of we're feeling a little better about the use of high dose nitroglycerin, I kind of wanted to talk about how we'd actually do this for a patient. So, as I'm sure you know, there are many formulations of nitroglycerin available, and this can range from your sublingual tablets and sprays to a topical ointment or a patch, the intravenous product. And it really opens the question of how do we administer nitroglycerin to SCAPE patients? Um, it's important to note that our intravenous and sublingual products have the fastest onset of action and should be used over the ointment since the goal of SCAPE is rapid resolution of symptoms. And your patients that are coming in via EMS to the emergency department may have already actually received some form of nitroglycerin prior to our arrival. So it's really important to make sure we get a good story and report from our EMS team and ask what was given and how long ago they received that nitroglycerin product. And at this point, it leads into the question of whether or not we should be giving additional bolus doses of nitro or just starting the infusion. So the literature I previously discussed all utilize some form of bolus dose, either alone or in conjunction with a nitro infusion, which most likely has to do with the goal of rapid symptom resolution. So the faster that we can get the patient on a high dose nitrotherapy, the sooner we can see the patient improve and prevent further decompensation. The bolus dose could be reduced if the patient had already received some amount of nitro en route to the hospital, since sublingual forms of nitro last for about 25 minutes. But in general, it seems to be appropriate to utilize a bolus dose and infusion approach. Especially in our area out here, we have patients traveling from quite a whiles away to get to our hospital. So kind of knowing that time frame of when did EMS get to the patient, what time did they administer dose, how long was their ride to the hospital, we can kind of use that to frame our initial approach. So once we decided if we're going to give additional boluses or not, we should next be focusing on getting that infusion initiated. So the initiation rate of the nitroglycerin infusion should be started at 100 mics per minute or higher, which is preferred in order to target that arterial vasodilation and really lower that afterload. The recent case studies and randomized controlled trials, specifically Matthew and colleagues in the Siddiqa and colleagues trials, utilized an initial infusion rate of 100 mics per minute and titrated up from there based on patient response and symptoms. Siddiqa and colleagues showed that the high dose nitro led to a faster resolution of symptoms in comparison to a low dose infusion and reported no adverse events, showing that this strategy was both safe and efficacious. The nitroglycerin infusion should be continued until the patient is showing signs of resolution of SCAPE, which has been recently defined as a decrease in respiratory rate by about 25% from baseline or to less than 24 breaths per minute, along with the ability to maintain oxygen saturations greater than 90% on room air or greater than 95% with supplemental oxygen, and a decrease in systolic blood pressure to less than 160 systolic or a MAP of less than 120. So as we continue this nitroglycerin drip, we're going to continue monitoring our patient. And once your patient begins to meet those criteria that I just outlined, you can begin to rapidly down titrate their nitroglycerin. The study by Matthew and colleagues reduced their nitro infusion by about 20 mics per minute every 10 minutes until discontinuation. And thinking about the fact that the nitroglycerin infusion has a relatively short duration of action, so quick on, quick off. If we're using that in terms of our titration, we can really get these patients off this drip rather quickly. So I've talked a lot about nitroglycerin drips, and that is the backbone of therapy here. But I do just want to briefly talk about some other treatments. So loop diuretics are another agent that's commonly used in patients with acute decompensated heart failure episodes. And they can be used in patients with SCAPE, but they should not be the main focus of our treatment here. So the onset of action of a loop diuretic can actually take about 30 to 120 minutes to have full effect. So it will not provide the rapid symptom relief that we're really looking for in our SCAPE patients. And also a key point here is that patients presenting with SCAPE are often euvolemic or hypovolemic and only seeing fluid overloaded due to the redistribution of intravascular fluid to the lung secondary to that increased afterload and catecholamine release. Also, there is the potential that loop diuretics can actually worsen SCAPE through the activation of the RAS system, causing increased vasoconstriction and increased left ventricular filling pressures. And throughout various case reports describing patients with SCAPE, loop diuretics have been used, but they likely did not contribute to the resolution of symptoms in these patients. Also, your patients with SCAPE, sometimes they can actually not respond to high-dose nitroglycerin as we would hope they would. These patients are actually referred to as patients with refractory SCAPE. So in these patients, we can actually consider the use of additional vasodilators to aid in their symptom resolution. And nicardipine, which is an intravenous dihydropyridine calcium channel blocker, can be used as an add-on therapy in patients with refractory SCAPE to assist in blood pressure and afterload reduction. So that was a lot, and I hopefully covered it all relatively in depth. But some key take-home points that I kind of want to use or speak to wrap this up really includes that the high-dose nitroglycerin combined with non-invasive ventilation is our mainstay of therapy for SCAPE patients, and this should be the backbone that we're relying on. Um, Administering those bolus doses of 600 to 1,000 mics and then initiating nitro infusion at greater than 100 mics per minute allows us to target that arterial vasodilation and afterload reduction, which is our main kind of point in terms of the mechanism of SCAPE. And finally, those case studies and randomized controlled trials have shown that the use of high-dose nitroglycerin is a safe and efficacious therapy for the management of SCAPE, and we should continue using it in our future SCAPE patients.
Well, what a great pearl. I love the point about EMS administration. I think that's always important, but especially something like this where, sometimes you'll get three sprays, maybe you haven't seen the effects and things. So, a couple other points I always like to remind folks, if you're going to use the spray, prime it. Gotta do that thing 5 times. I promise you, if you don't remind them, they're not doing that. But we're talking a lot about this high dose nitroglycerin therapy, and I guess we just need to reiterate that like this isn't without risk if you're not using it safely and appropriately. So, things that you hinted on were like communication, and I think that's so key, especially if you don't have it protocolized, if you're not using it routinely, kind of being by the bedside, maybe right outside the room, depending on your layout, to be there as a resource just to make sure everything's okay. But huge shout out to Caylee. Let her know what an awesome job she did. She's on Instagram at Caylee.b10. Appreciate you coming on, sharing your knowledge about this emergency medicine disease state, Caylee. So thank you.
Thanks.